We really don't want patients to have to be readmitted. Patients, when they leave, want to stay in whatever setting you send them to, whether it's at home or to the nursing home. What was happening was not adequate, and we sensed that because in '09, we were about 1% higher than the Iowa average on our readmission rates for 3 disease groups.
So what can we do to address that from a patient-centered standpoint as opposed to working in our silos and not collaborating with others? We recently had a patient that was readmitted to the hospital 7 times during an 8-week period. Okay, who can we pull in that is important to this patient?
2 things we needed to change at Finley Home Care. The first thing we did was develop case conferences. They were on an every 2-week basis, maybe once a month, where we would sit down and talk about all of the patients in a nurse's caseload. How often we were seeing them, why we were seeing them. We weren't always talking about the things that we needed to talk about when we needed to talk about them.
To the patient, we're obviously not doing it in an effective way. They have needs that aren't being addressed. So there's a lot of different things that can be going on with this patient, and it's through those case conferences that we identify them. What we decided to do was have more frequent meetings, more often for shorter periods of time, but on one patient. So we're really identifying and focusing on that patient's needs and not feeling pressured or rushed to get through the entire caseload, which at times can be difficult. So feeding off of case conferences are interdisciplinary team meetings. So at the case conferences, we identify patients that have highly complex needs. So case conferences are done with every patient. Interdisciplinary team meetings are only done with select patients that are at risk for readmission to the hospital.
So we were having an IDT meeting on this particular patient.
This person was going to go to a nursing home. This was a person that the hospital didn't know what to do with until they got in the home. And then they realized, oh my gosh, look at all the stuff that's going on here.
You know, we needed a suggestion, we needed a change.
This patient was not taking blood thinning medications properly, has mental health issues, is deaf, has a mother who cannot read. And once we were able to see this patient, we were able to look at what happened in this specific situation, specific to this patient that caused this patient to go to the hospital.
By using case conferences and IDTs, we're able to wrap all the services around a patient that they need in order to prevent them from going back into the hospital. Normally we wouldn't have had that type of interaction. In the past, when we did interdisciplinary team meetings, we never really felt like we developed a plan of action when we were leaving the room. It was more just getting together and talking about the patients that we felt needed to be talked about. Now when we sit down and have an interdisciplinary team meeting, we have so many patients that we're talking about that we need to do it more than once a week. We get input from all of the people involved in that care and also input from people that might have insight that we don't, like a dietitian or the wound center.
That's what we're here to do. We were able to get in there, figure out what was going on in the home, and add value for this patient and the patient's family.
The impact these changes have had on the patients is just tremendous. Our acute care hospitalization rate has dropped significantly in the last year. It's really helping our patients stay at home where they want to be and not in the hospital where they don't want to be. Since we've made these changes, I really feel like my job has become more to help coach and mentor our unit coordinators and our nurses to do the great patient-centered care that I know that they can provide. It's no longer just checking boxes on a form. I'm able to help them think about, okay, what does the patient really want? What does the patient really need?
For nurses, there's a reason they got into this field, and that's to provide high-quality care to their community. And so I think these programs have helped. I think it's a starting point for us, but it's going to be a continual, ongoing effort every single day. And they're living and breathing it. They're out there going into homes and seeing things that other providers may may not see. What gives them fulfillment, what gives us fulfillment is when we can do our best to address those needs. That's what matters. Certainly our staff feels better about the care that they're providing because of programs that we're using. And again, these are not necessarily fancy programs or fancy initiatives, but again, they're patient-centered, and they may be considered smaller things, but they, trust me, are very complex and hard to implement, hard to sustain, can have a large impact. But we want to meet the patient's expectations every single time and exceed them. And if we do that, we'll probably be much better off in the long run.